Hello and welcome everyone to this joint ASHNR ESHNR webinar. I'm with my colleague from the American side, Maylan. Hi, Maylan.
Hi.
And we've got great guests today. We're going to just wait for people to filter in through the Zoom. Just takes a few moments before we actually start the formal webinar. Okay. I think a number of people have already filtered in. So I'm going to hand over to Ram Vidyanathan from Leicester, UK, and Seth Stalcup from South Carolina in the USA. Over to you, Seth.
All right, thank you. Welcome, everybody. We're very excited about this webinar today. Hopefully it's very informational. To start off, just a few housekeeping things. There is a Q&A panel to ask questions. We hope to have a lot of interaction from the audience following the presentation, so please enter your questions there and then use the chat box to discuss and connect with your fellow attendees. There is CME credit available. You can read all the disclaimers down there and file for that afterwards if you're participating in this activity. The learning objectives, upon completion of this, we want you guys to have a better understanding of the surgical considerations for anterior, middle, and posterior craniofacial lesions, different surgical needs for adult versus pediatric patients, the joint neurosurgical and otolaryngological approaches to skull-based surgery. I do have to disclose that I am a consultant for Siemens Healthineers, but that has nothing to do with what we're discussing today. I want to put it on everyone's calendar, save the date, come to fabulous Las Vegas for the Head and Neck Radiology Society in September of 2025. It'll be at the Encore, so mark your calendars now for that.
Thanks, Seth. I think exciting times for both societies, the ASHNR and the British Society of Head and Neck Imaging. We started this program this year having a joint visiting professorship, and Geeta Madani, our first professor, did visit the West Coast, and we are hoping that Mohit will be here sometime in 2025 as the first American professor. Next, please, Colleen. And on behalf of the ESHNR, it's my pleasure to welcome to my home country, UK, for the next year's ESHNR in Glasgow. Scotland in September is a fantastic time to be there, and I'm hoping to see more of you. Next. The next ESHNR case webinar is on the 19th of November, and you've got some lovely speakers there, both Chris Moyes here from US and Ravi Lingam from the UK. Next, please. And the ESHNR story continues with the webinar on 26th, which is on infectious and inflammatory processes of the temple bones. Again, by another famous name there, Prof. Mukherjee. And please do follow us on social media. We are on Twitter or X, as well as on Instagram and various other places. Do follow us, gives us a thumb up. Okay, next. Over to you, Seth.
All right, I'd like to introduce Dr. Michael Chicoine, who will be a neurosurgeon here lecturing up for us today. Dr. Chicoine was born in Chicago, Illinois, and attended undergraduate at the University of Illinois, Urbana-Champaign. He then went on to complete medical school at UCLA before coming to Washington University in St. Louis at Barnes-Jewish Hospital for his neurosurgery residency. Finished that with a skull-based fellowship at the University of Cincinnati, and then returned to St. Louis as a neurosurgeon for over 25 years at Barnes-Jewish Hospital. He has published over 150 articles, and he is also the skull-based section editor for the Neurosurgery Journal. And then in 2022, after more than 30 years at Barnes-Jewish, he made the move to Columbia, Missouri, to become the inaugural chair of the Department of Neurosurgery at University of Missouri, where he's professor of neurosurgery and otolaryngology and the Hugh H. Stevenson Endowed Chair of Neurosurgery. So thanks for joining us today, Dr. Chicoine.
My pleasure to talk about Dr. Rivera here, who's a board certified otolaryngologist, a neuro-otologist. Marlon told me that his practice is so busy that he's just about to be joining us very soon. He specializes in lateral skull-based surgery. He serves as the professor of otolaryngology at the University of Missouri, where he combines his expertise in complex skull-based pathology with a deep commitment to advancing the field of hearing restoration. He's passionate about the use of implant devices for hearing reconstruction and has pioneered innovative approaches to improve outcomes in these patients. He's recognized in the leader in the field of in his field and as an advisory position with the FDA for ENT devices, where he's contributed to clinical expertise and the development and regulation of emerging technologies. He is also retired from the U.S. Navy as a captain with extensive experience in leading multiple overseas humanitarian missions. In addition to his clinical and academic roles, is dedicated to mentoring the next generation of otolaryngologists and neuro-otologists, and his work continues to shape the future of ENT care, both nationally and internationally. So welcome.
Yeah, thank you for the kind introduction. Can you all see the PowerPoint okay?
Yes.
So again, many thanks for the opportunity for three of us to present to you today. We're going to talk some about the imaging in skull base and how we translate that into our clinical and surgical management of these patients. Probably have a few too many slides here, so we'll kind of skip through these as they are of interest. A little bit, here's our campus here in central Missouri. We're on the south end of this campus, has been here for about 175 years, said to be the oldest public university in the U.S. West of the Mississippi. The med school has been here for about 150 years, and neurosurgery has been here for about 70 years. Here's some of our growing campus. You see here, for those who don't know the geography, here we are kind of in the epicenter of the United States there. A number of people have come out of this institution over the years. One name that you may know, Dandy of the Dandy Walker malformation. Others did some of his early training here at the University of Missouri and was born just a short distance from where I sit now. Al Roten, kind of a legend in skull base, did much of his early training here, and the late Al Roten, really encyclopedic knowledge of the skull base and central nervous system anatomy. He would say that the brain is the crown jewel of evolution and creation, and talked about making our surgeries more precise and careful. So as you heard, these are some of our objectives: to talk a bit about lesions of the anterior, middle, and posterior fossa skull base in both adults and children, and how we as neurosurgeons and otolaryngologists interact with our neuroradiology colleagues to try to find the best solutions to these problems. So we'll go through some cases here. Here's the first one. A young woman, young girl, 12 years old, with facial pain, particularly in the V2 distribution. And the imaging there, Dr. Ho, if you can give us an overview there.
Yeah, so we've got some coronal images on that left side there, and you can see some expansile masses, which are in the expected regions of the foramen rotundum and Ovidian canal. So then when we go to the axial images here, we see this smoothly lobulated lesion arising from the trigeminal root exit zone and really tracking through Meckel cave with lobulations along V1, V2, and V3, but primarily V2. And then as you go to the right there, you see that there's also involvement, go back one, sorry, to the pterygopalatine fossa. So essentially what this thing is doing is crawling along trigeminal nerve, pterygopalatine fossa, and then coming back along the Vidian. So it's got that plexiform kind of morphology where it is involving multiple interconnected nerve roots. The signal characteristics are kind of combined, solid, and myxoid. So, and it's obviously in slowly progressive lesion with these lobulations and the smooth bone remodeling.
So when we think of lesions in the various cranial base fossa, think about what the differential is. I threw in just a few slides of some of the mimics. One concept is we want to make sure we are approaching the correct pathology. So here's an unusual case of Erdheim-Chester's disease, a renal cell metastasis, aneurysmal bone cyst, here a lymphoma, here a case a couple of cases of IgG4 related disease. So any hints we can get in terms of what the pathology may be is going to significantly impact what our approach is, maybe just a biopsy or maybe a more elaborate resection and or other treatments. And we think of lesions, according to which fossa they are in, anterior, middle, posterior fossa, or combinations. This particular lesion turned out to be a neurofibroma, although in many ways our approach to this is similar to how we approach trigeminal schwannomas, as you see here. And so a whole variety of surgical approaches that we might take for such lesions, and we'll walk through some of these various avenues to the skull base, as well as other treatments, including radiation. And you see here just some depiction of the various avenues in this cartoon here, whether they're anterior approaches to the sinonasal cavity or anterior skull base, middle fossa or posterior fossa. And you see a few samples here from that article just demonstrating various approaches.
Okay.
And more, we do a lot through the endoscopic endonasal approach, something that's evolved quite a bit in the last 20 years, thinking about this anatomy through a different view than some of our traditional approaches as well. And here's just an example where a middle fossa lesion addressed to an endonasal approach by Ted Schwartz and his colleagues in New York. But a lot of traditional cranial approaches, as you see here as well. So here's kind of a traditional frontotemporal approach, typically incisions behind the hairline. We can do adjuncts to that, such as the addition of the orbitozygomatic approach, where we can take off the orbital rim and zygoma to give a more expanded approach, as you see in a case like this, the right frontal and temporal lobe dura and the orbit there, in various stepwise techniques that we use to expose that anatomy. And here a beautiful illustration from Aaron Cohen-Goodall in a cadaveric dissection, how we can display that anatomy to get to the pathology. Another tumor in the same general neighborhood, if you will, a large trigeminal schwannoma in a young person. And here's an intraoperative image of that. So on the right side, the frontal and temporal lobe dura, and you see that tumor. In this case, that we at least initially exposed primarily extradurally. You can see the fibers of the trigeminal nerve overlying the lesion there and coming out of the floor of the middle fossa. And then thinking about reconstruction. So here's the preoperative images there. We've used the temporalis muscle to reconstruct the floor, and then titanium and other autologous tissues to reconstruct that. And then when we think about the middle fossa, this is kind of in our mind's eye what we think about the floor of the middle fossa. And thinking about that anatomy, that'll come into play in some of the other cases. It looks like Dr. Rivera has joined us, and maybe Arnie, if you could, from your perspective as a neuro-otologist, talk a little bit about some of the aspects of the anatomy in the floor of the middle fossa and the skull base.
Dr. Chicoine and I work together, Mike and I work together on these type of procedures. And important landmarks for me as a neurotologist to navigate the middle cranial fossa safely, it's number one, finding, I use the external auditory canal as a landmark, because if you see the external auditory canal will be in continuity with the internal auditory canal. So as we're talking about the case and prepping the patient, we are looking at to where is the external auditory canal, and if you follow a CT scan or an MRI, they are in continuity to each other. So it's a great landmark to have. Also, the root of the zygoma, this root of the zygoma is a good landmark to where the temporal lobe sits on the middle cranial fossa as we plan our craniotomy to expose the landmark. As you can see on this picture, it is anterior, more anterior than some people will, without experience, realize they have to place the craniotomy to be able to see the internal auditory canal and the floor of the middle cranial fossa without too much shadow effect of.
Did we lose Arnie there?
I think we lost him.
Okay, I'm here. Can you hear me?
Yes, sir.
My apologies again. So when as a neurologist, the landmark that I use first and foremost to find the internal auditory canal before I start drilling bone is the arcuate eminence, or the superior semicircular canal. So which is that right there. Is that you, Mike?
Yes, sir.
Thank you, Mike. Thank you. So as you can see, it's roughly 70-degree angle between that and the internal auditory canal. And then we use a surgical drill to start drilling that. Also, you can see GSPN, greater superficial petrosal nerve, right there. We use those two landmarks, and then we start drilling the bone. And then what we're looking for is the facial nerve, the cochlear nerve, they will be on top of the internal auditory canal there. this facial nerve, and then the superior vestibular nerve just anterior to it. Cochlear nerve will be medial or deep to it. The cochlear will be anterior and medial to the superior vestibular nerve. And we use those landmarks to continue drilling safely and expose that so we can remove these tumors.
And for the, kind of the non-surgeons in the audience, so this is kind of in our mind's eye. Obviously, a lot of this anatomy we can't see when we look at that floor of the middle fossa, and this is an extradural approach. So it's, Arnie's exquisite understanding of that anatomy that enables him to drill around there and, working between these delicate structures. And again, we tend to do a lot of preoperative CT imaging to understand the bony relationships, the pneumatization of the mastoid, how large or small that presigmoid space is, how high the jugular bulb is, and various things like that.
Correct. Also, the position of the major vessels is very important. We don't want to get into those inadvertently either.
So here's a similar case, a young gentleman with multiple tumors, but in this particular case, that middle fossa trigeminal schwannoma, and this NF2 individual is growing. So again, this is kind of that surgical approach. We're on the right side, primarily extradural to start with, and drilling down some of that floor of the middle fossa. And from this approach, we can see foramen rotundum, foramen ovale. We can see that tumor bulging there initially through this extradural approach, as you see there. And then this is sort of the consistency of a lot of these tumors, schwannomas and meningiomas, often this sort of rubbery consistency. Some things are softer. Sometimes we can appreciate that from the preoperative MRI where there's, brighter on T2 and whatnot. And the consistency of the tumor may impact how we approach that as well. You see the tentorial edge there as we work towards the posterior fossa from the middle fossa. And I think a little bit later you get a little bit of a glimpse of the fast forward here of the fourth nerve here. There's a little bit of the temporal lobe there. Back up there just a second there. Right there at the base of the, it's hard to see, but right at the base there is the midbrain. So using a little bit of that anatomy to get to the lesion. Here's a smaller lesion. Now this is interesting. It happened to be the son of a ophthalmologist that I knew, and we typically use a skull-based approach. They were very adamant they didn't want any surgery. And this young gentleman had radiosurgery, and so far after about a decade, that's it's kind of kept that thing in check. But radiosurgery in some cases can be quite effective, but we have to kind of use all the tools in the toolbox. Here another case of kind of a zebra. This what me and my neuroradiologist at the time thought was going to be multiple meningiomas turned out to be sarcoidosis. So kind of keeping these variations in mind. So here's the next case, a 20-year-old who has a history of osteosarcoma, been treated actually in another country, in Pakistan, presented with some nausea and vomiting, and see this lesion there. Dr. Ho, if you could review that one.
Yeah, so we've got a very densely calcified mass arising from the calvarium with osteoid matrix and aggressive heron and periosteal reactions, so suspicious for metastasis. And you can see along that medial edge, there's actually kind of a nubbin, exophytic nubbin. And that's actually what we call the volcano sign. So that's a sign of dural invasion. So it's actually got epidural and subdural components. And you see the parenchymal edema and mass effect. I think there's an MR as well. All right, so on the MR, we've got the face map shows both dense calcification as well as intraparenchymal hemorrhage. And again, you see that that dural invasion with the exophytic components. So we've got both the extra and intraaxial components.
So this is a case that one of my other colleagues and Dr. Rivera managed, and I don't think the diagnosis was in question. He had known osteosarcoma, but how to best manage this, a lot of mass effect, try to relieve the mass effect and deal with the portion of this was dealing in the extending into the skull base. And maybe Dr. Rivera, you have some comments about how you all manage this case.
Yeah, can we go back to the CT for a second? So we saw that was a significant invasion of the temporal bone and the external auditory canal. So I began the surgery, and what I did, I completely surgically removed the external auditory canal and all the soft tissue lateral to the inner ear. And I did a cul-de-sac, or I blind sacked the ear. I also removed all the or as much of the air cells of the temporal lobe, as well as the bone between the tegmen tympani and tegmen mastoideum and the temporal lobe. Then Dr. Euclid and Andy came in and removed the metastasis from the temporal lobe. And there was, if we go back to the MRI, there was this lesion here. I don't know if you guys can see my cursor. That he removed. It was a solid lesion. He was able to remove all of that, and the kid did very well. Right there, Mike. Thank you. Right there, correct. It was a beautiful dissection. I removed all the metastases for the temporal bone and the external canal. Then we packed that with fat, and Andy removed the tumor from the temporal lobe.
And so this, this case reminds me of, some of these collaborations between neurosurgery and otolaryngology. Dr. Rivera talked about blind sacking the external canal, essentially amputating the external canal and oversewing it, which gives tremendous access. It also is, something we as neurosurgeons are not necessarily comfortable with. And also this issue of leakage of spinal fluid, which in many of these cases, is a potential postoperative, sometimes preoperative problem, and how we manage that, sometimes with spinal drains or ventricular drains or even permanent shunts and things of that nature. So, and certainly, the function of the various cranial nerves is important, assessing them preoperatively and trying to preserve them, maintain them postoperatively. Audiograms are an important part of that. Here's one audiogram here. Maybe Arnie can comment on this. There's, I think, another audiogram or two later in the presentation.
Absolutely. So you see there an audiogram, and the right ear is completely normal, okay? And the person has profound hearing loss in the left ear with zero understanding. So completely deaf in that ear. And then I think that correlates with that MRI.
As he said, so here's since he doesn't have the pointer here, so the right ear is perfect. All the circles and whatnot are up at the top. In the left ear, the significant decline. Once it gets below 50 here, non-serviceable hearing. The word recognition score here, 100% in the right ear, 0. So a dead ear, if you will, and that impacts again our approach. Are we going to try to save hearing, the labyrinth, or is that not a worthwhile pursuit? Sometimes angiography, sometimes the vascularity of these things. What is the anatomy of the sinuses? Oops, sorry. It's wanting to skip on me there. The transverse sigmoid sinuses, as I mentioned, the jugular bulb. There may be cases where we do preoperative angiography for embolization. And then looking at that anatomy, this cartoon, sort of this typical anatomy that we see in a retrosigmoid approach, looking at the lower cranial nerves, and then up, we can see is up to the third nerve. And these are some of the most typical approaches that we use for lateral skull base, middle fossa, retrosig or suboccipital or translab, and then some variations or combinations of these things. If Arnie, you have any sort of comments about these sort of general approaches to the skull base?
Absolutely. So as you mentioned, in my mind, I look first at the hearing, and are we going to try to do a hearing preservation approach or not? So if we have options here, so suboccipital or retrosigmoid, or pre and post sigmoid may give us a good exposure with a great opportunity to preserve hearing. So those middle cranial fossa for small to medium-sized tumors that are basically in the internal auditory canal. When hearing, it's not worthwhile preserving, or when the tumor is 2 centimeters or larger, it's worthwhile considering non-hearing preservation approaches, translabyrinthine craniotomy being the most common one that we use.
Here's just a little example of a middle fossa approach to what we might refer to as an anterior petrosectomy, or sometimes you may hear the name Kawase's approach. So this is looking extradural in the middle fossa for a lesion such as this. Anterior to your left, posterior to your right. This is extradural, the middle fossa. So we've done a craniotomy coming here beneath the temporal lobe under this retractor here. This is the bone of the skull base, kind of like this cartoon here. And so this little stimulator is stimulating the GSPN, getting a retrograde stimulation of the facial nerve. And the GSPN may not be so visible. And this is the anatomy in the cartoon that we know is there, but this is what we see. Like Arnie said, the arcuate eminence, the prominence of the superior semicircular canal, the GSPN. So this is the bone that we may want to drill here. And so, having a neurotologist like Dr. Rivera with these skills is tremendous help. So, taking out that petrous apex there to give us a little bit lower approach, and then opening the dura here, and then going, both intra and extradural in this case, taking out some of that bone till we get to this this lesion there. There you see the brainstem there. So that's the lateral aspect of the cerebral peduncle, maybe the posterior cerebral artery there. And then you see a little bit of cerebellum to the back here. So we've got a combination of a middle and a posterior fossa approach here. You got a little glimpse. That's probably the fourth nerve, that little twig of the nerve, probably the the most delicate of the cranial nerves, the fourth nerve there. All right, so case 3. So this is a case from some years ago that I believe Dr. Rivera and one of our former colleagues treated a 15-year-old young woman who presented with mixed hearing loss. Another audiogram there that Dr. Rivera can explain these squiggly lines to us.
So yeah, so here you see left here, so 25 decibels and above is completely normal. So this young girl, she was 15 years old then. She has normal hearing on the left here with 100% word recognition score. So that's completely normal. And suddenly she lost all her hearing in the right ear. In the right ear, she has profound hearing loss. It's below 80 decibels. And her recognition score is 0. And as Mike mentioned before, we have the 50-50 rule, so if they have 50 decibels or above, or if they have an understanding of 50 and above, we consider that serviceable hearing that is meaningful to the patient. Below that, it is not. But she's way below that. She has basically a dead ear on the right side.
And there was a tympanometry as well.
Yeah, those are middle ear pressure that are normal in both ears.
So here's some images. So she had a transcochlear approach. I think I've got some images of that. This to me, and maybe Mylon, you can comment on some of the imaging here. It's kind of an unusual case in terms of its involvement of the petrous apex.
Yeah, it really is. So, I mean, there's some features compatible with schwannoma. It's a mixed solid cystic. It's got that smooth bone remodeling, and it does enlarge that cochlear aperture. So it looks like it's involving cranial nerve 8, but it's very unusual, that amount of transverse kind of extension and kind of just obliterating the IAC and extending to the petrous apex. So I was kind of curious for Arnie, back when you operated, was there anything unusual about the pathology that would explain this growth pattern?
So we were not sure what we were looking at. We thought that, probably the most common thing will be a schwannoma, but due to her age, we were, at the presentation, we were concerned that maybe there were other hidden or more concerning tumors in that area. We had the conversation with the family, and otherwise her cranial nerve exam was completely normal. So what we did is that we did a transotic, which we removed both the cochlea and the labyrinth. I also oversawn or blind sag the ear canal. And as I was drilling both the labyrinth and the cochlea, was easy for me to find the facial nerve unprotected. And I started removing, by the time we got to her, we started drilling the cochlea and the labyrinth, we started finding tumor in both the labyrinth and the cochlea, and we sent some for frozen and came back benign, consistent with a possible schwannoma. And at the end, the pathology was consistent with a schwannoma. She had what we felt was a complete resection at that time. And we packed her cavity with fat. And then we ate her with a bone conduction hearing device because she was completely deaf in that ear. And for a few years, she was doing very well without any obvious recurrence of her tumor. You can see some of what we did there in that representation. You start this just first removing the extraordinary canal and drilling portions of the mastoid bone, and then engaging the labyrinth and the cochlea. And while you're drilling, the facial nerve is in between both structures. So we take a lot of care right there, thank you, Mike, protecting that. And we were able to navigate those structures. And she woke up smiling from that surgery, which is very rewarding for all the involved parties.
This, for the non-surgeon, this is, the lesion's a right-sided lesion. These, beautiful drawings from Dr. Jackler's atlas from Stanford is a left-side approach. But so you're on the left side, behind the, as Arnie said, the left ear has been mobilized, blind sacked, sigmoid coming down to the jugular. So this is our pre-sigmoid approach there, the facial nerve skeletonized and fallopian canal there. And as Arnie said, removing the cochlea anteriorly and the labyrinth posteriorly. And then, as I mentioned earlier, we look at the preoperative imaging, look at the jugular bulb and some other features. Sometimes there may be a very high riding jugular bulb that may make access to the IAC a challenge. And so that may lead us to modifying that approach.
Yeah, also in this particular approach where it's petrous carotid, because we are navigating very close to both the petrous carotid and the facial nerve as we remove the cochlea. We get very close to both structures, so we blue line them, we protect them, it worked beautifully for her.
And as Dr. Jackler draws in this case, the concept of mobilizing the facial nerve, something we probably do less often, I would think, Arnie,
now with the advance of early detection and also radiosurgery, rarely we have to mobilize the facial nerve anymore. That has a lot of morbidity. Most of those patients, as don't recover normal facial nerve function ever. So we do that only when we really need to.
And occasionally there may be like the rare facial schwannoma where maybe the face is out already, and then with Arnie and his colleagues, we can try to reanimate the face, maybe do a interposition nerve graft for the facial nerve if needed, or things like that. Uncommon.
So we have a couple of those hovering, people with large facial schwannoma, very large facial schwannomas have undergone radiosurgery, and we are monitoring for progress or deterioration in the future. But yeah, when that happens, then we go deep into the CPA and remove the facial nerve and the tumor, and we follow that to sometimes down to the stylomastoid foramen. We have to remove that right there, Mike. Thank you. So sometimes very hard to reconstruct with a cable graft in that situation. They need other modalities for both static and active facial nerve function.
You may see the gold weight or the platinum weight on the CT or MRI that some of these patients with facial nerve paralysis that really can make a big difference for protecting their eye. There's some more cartoons from Dr. Jackler, and here here's the fallopian bridge. We like Dr. Rivera was saying, keeping the nerve intact and working on either side of the nerve. And then some more elaborate approaches like this, where we may be pre and post sigmoid and both in the middle and posterior fossa, and sectioning the tentorium, sectioning the superior petrosal sinus, and sometimes for larger petroclival tumors, or like this cartoon describes for a mid-basilar aneurysm. And just some, here's a dissection from Dr. Roten, the late Dr. Roten, but again, on the left side, some of that, beautiful anatomy, the sigmoid skeletonized, the transverse middle fossa here. In this case, a retrolabyrinthine approach, the labyrinth preserved. It's a pretty narrow window off in that pre-sigmoid retrolabyrinthine space. And again, the jugular bulb may come into play depending on how high it is. This was a group at Duke and Dr. Fukushima from Japan, a nice paper on this approach some years ago, sigmoid and transverse middle and posterior fossa and so forth. And again, the exquisite cranial nerve anatomy, this gives us access to try to preserve. Here, this is an unusual case, a young woman with bilateral tumors. She had a SMARC gene mutation. Both she and her young daughter had the same mutation and kind of identical tumors, but a right-sided meningioma, approach to a combination of a sigmoid and pre-sigmoid retro-lab approach. And this is her initial post-op, and then that left-sided tumor grew, and then she had kind of a similar approach on the left side later. And so this is kind of a workhorse, in the CP angle, whether it's translab or retrosigmoid, is working in that CSF space between the cerebellum and the temporal bone, and identifying and preserving those cranial nerves. So here's a video. It's kind of an older video. The resolution may not be great, but gives you a little bit of a sense from a right-sided retrosigmoid. There's the tumor there. Again, that kind of firm, rubbery component or consistency. The lower cranial nerves to the right, stimulating, try to find the facial nerve, debulking that tumor there. As we're able to get the tumor debulked, that starts to give us access to the seventh nerve, which is typically on the deep side of these vestibular schwannomas. But it can take variable course. So there's the nerve at the end, trying to stimulate and preserve that facial nerve. And again, we may use combinations, with Dr. Rivera's expertise, translab, retrolab, retrosigmoid, or combinations of all of these. There's another, this is a little bit more inferior, the jugular foramen schwannoma. This is in a young guy with NF1. You can see here on the right side that sigmoid is skeletonized. The retro, in this case, so going down here, down to the junction of the cervical medullary junction, opening up a little bit of that dura down at the upper level of the spinal cord, getting into cisterna magna, getting some brain relaxation of the cerebellum there. And you can see working pre-sigmoid there to get to that tumor there. So this is that young woman that Dr. Rivera is talking about. So she had tumor resected a few years ago, and unfortunately, it looks like it's slowly coming back. And we've got I don't know if Dr. Ho, you have some comments on these follow-up scans.
Yeah. So just a bit of a solid cystic residual in the deep petrous apex there, and then we can just cycle through the subsequent imaging. Basically, there's kind of more solid stuff growing into it and starting to get closer to that residual surgical bed in 24.
So a bit of a challenging thing if she's young, and if she were 70 or 80, I might think radiosurgery, but she's got hopefully many years ahead of her, and so I think some further surgery is in order for her. Dr. Rivera and I will probably address this sometime in the coming weeks. Any thoughts about the situation now, Dr. Rivera?
Oh, I agree with you. The good thing is that the first time it's there's nothing good about her situation, but the first time we remove a lot of structures between us and the tumor, so we may have a pathway back through the old approach. We ordered some CT scans to see how that anatomy looks today. It's close to the pitch carotid there, and if we have to, we can blue line that a little bit more. It's the cochlea has been removed and the labyrinth, so we have to we can work anterior or posterior to the facial nerve in that area. We can also, if we have to, do a small middle cranial fossa, a small cranie to work a little bit from above. It depends how it looks after we're engaging it. But I agree that we should be able to navigate that area and remove more of that tumor.
All right, so I think we have one more case. We have time to go through this last one then. So we have one last case. So this is a 51-year-old gentleman with 6 months of progressive sinonasal congestion and headaches, some altered mental status, and this fairly dramatic lesions you see there. If Dr. Ho can walk us through that one.
Yeah, so I've got the intra-op CT and then an MR. And so we have this sinonasal tumor. Looks like it's involving the, like middle secure turbinates growing through the cribriform plate there. and then invading into the frontal lobe region. So there are a number of peritumoral cysts, and so that's classically described with esthesia neuroblastoma, although theoretically could be in other invasive tumors as well.
There's some of the post-op, I think, on that one there.
Yeah. So they had been, after that treatment and radiation and chemotherapy, all of this, they had been stable for a number of years. But then we did notice recently a recurrence in that left frontal region there, kind of the terional region. So although it's dural based and, statistically in someone without this history, you might think of other extraaxial lesions like meningioma. But given this history, we were pretty suspicious for recurrence.
So for esthesioneuroblastoma, I think the general consensus is, maximum resection. For smaller lesions, largely limited to the sinonasal cavity, maybe an endonasal approach alone will suffice. But for these bigger ones, some kind of combined craniofacial approach. And then we not only think about how to get it out of there, but how to reconstruct it, because these people typically get treated very intensively with radiation, which will impact the healing of that. Now, for, say, a sinonasal undifferentiated carcinoma, at least some would advocate upfront radiation and chemotherapy. So, in many cases, we'll biopsy these before making a definitive treatment, but a whole variety of approaches, traditional craniotomies, endonasal approaches. In some situations, not so much for big aesthesia like this, but for some anterior fossa lesions, these eyebrow approaches, and thinking a lot about that anatomy of the anterior fossa, the bony anatomy, the frontal bone, the sphenoid, the ethmoid, the soft tissue anatomy. Often the orbit comes into play in these tumors, so it may not only be a neurosurgeon and a otolaryngologist, but sometimes ophthalmological surgeon as well. In many cases, we may be trying to identify where the anterior and posterior ethmoidal arteries are and the supply to those. Sometimes those can be embolized or sacrificed early in the case. Some cases, preservation of olfaction. By no means in a case like that one presented, but for smaller lesions, benign lesions, sometimes we can preserve olfaction. In some of these traditional approaches, reconstruction is often done with this pericranial flap, which is a very, very robust technique. And we can not only get to the anterior fossa, but for some of these more complex tumors, we can get down into the sinonasal cavity, even down to the clivus, even down to the foramen magnum in some situations. And again, thinking about this anatomy through an endonasal approach, much more now than we did 20 years ago. So this is just one example of Wolfgang Draffa, a legendary otolaryngologist who taught us a lot about the variations in the anatomy of the frontal sinus, which impacts our surgical approach. Some people have virtually no frontal sinus, or early in life, there's little, if any, sinus, and that may impact our approach. Here's just an example of using the frontal sinus as an avenue to the anterior fossa. So some examples of that. So, over and over again, I emphasize with our trainees, don't just look at the MRI, but look at the CT as well. Look at the pneumatization of the sinuses and other skull-based structures. In a case like this, we're able to make a small craniotomy through the frontal sinus and remove that tumor. You see in the pre-op here and the post-op here, and able to preserve at least one of the olfactory nerves, which does have some benefit for quality of life. Here's another kind of small, medium-sized anterior fossa tumor. And this is kind of the approach there. So I'm thinking about where her frontal sinus is. I've got her head extended a bit so the frontal lobes kind of fall off the floor of the anterior fossa. And we could get through this through the nose. We get through various craniotomies. Through the nose, I know for sure we're going to sacrifice her olfaction. So sometimes a little bit bigger craniotomy may give us good access and possibly enable us to preserve her olfaction. So here's a bicoronal craniotomy, preserving the pericranium, going through the frontal sinus, through the anterior and then the posterior wall. And sorry, let's just skip around here. So here's the craniotomy there, and using that pericranial flap to seal off the frontal sinus, which often will obliterate with abdominal adipose. This can be helpful for bigger lesions too. You see one here with some hyperostosis. I pay attention a lot to the size of that frontal sinus and whether that's going to be a useful corridor. Again, this kind of concept here. First removing the anterior face of the frontal sinus, and then basically craniectomizing. You're just completely removing the posterior wall. So try to show a quick video of that concept here. So we raise the pericranial flap as a separate vascularized flap, remove the anterior wall of the frontal sinus, remove the posterior wall. And then so here we are looking extradural to start with. That was the crista galli poking up there. We're opening up a little bit of the frontal dura there, and you start to see that kind of rubbery meningioma there, drilling out some of that hyperostotic bone of the skull base. So now we see the left optic nerve, the right optic nerve, the chiasm, and carefully trying to peel this tumor off the cranial nerves and the carotid artery, anterior cerebral artery, and so forth. You see there, start to see the left carotid artery here, just lateral to the left optic nerve. Here's the left carotid artery again coming in, a little bit atheromatous there. You see the anterior cerebral artery coming up over the chiasm there, and some of the beautiful anatomy we'll see there. And then reconstructing that again in some way to reduce the chance of CSF leaks. And so for a complex malignant lesion like the case that we presented, reconstruction is even more important because those tumors transgress the anterior fossa floor. Those patients have high risk of CSF leak. They tend to get intensely radiated, and so multi-layer closures. The nasal septal flap, using a mucoperiosteum of the nasal septum from one side, is very helpful for some of these endonasal approaches, but in these malignancies, it's been destroyed, so not so viable. But you'll see some examples of that. And so this is the concept of here's one of Dr. Rivera's colleagues, Dr. Tassone, coming through the endonasal approach, while we, the neurosurgery team, are coming from the transcranial approach. So we kind of meet in the middle to address these things in the anterior fossa. So that's, in a nutshell, the anterior, middle, and posterior fossa skull base. Thank you for your attention. We're happy to answer any questions if there are any.
I just want to say thank you to Mike and Arnie. You are inspirational, and like the joint approaches, helping our radiologists understand what you need from us, and a lot of the considerations you take into account. So I'm honored and humbled to work with you both.
Oh, well, thank you very much for the invitation. Having your expertise, your understanding of the various imaging techniques and helping us better understand this pathology before we get there. And then sometimes even more challenging is, after there has been treatment, trying to figure out, what that is over time, over the months and years after treatment. So it's a great collaboration.
Really to work with you, Alan. You make our life easy, reading all these complex films for us and always being available to chat with us. If we have any questions, we're always emailing each other when we see interesting pathology or things that don't make sense to us, but sometimes makes more sense to you when you review the films from us. So thank you. And it's great to work with someone so experienced. I learn a lot from Mike all the time. Sorry, I'm on the tail end of a call, so I don't have my voice, but it's great for me. I'm very humbling to work with you both.
Seth and Ron, do you have some questions?
Yeah, I thank you very much for that. Was very interesting. How often do you guys discuss these intraoperatively? Sometimes we've had discussions about the desire to have an intraoperative MRI installed and that sort of thing. Do you find that to be something you're lacking, or do you find it that normally with your preoperative evaluation you have a pretty good idea and some contingency plans for when you actually get in there?
Yeah, so intraoperative imaging is a very interesting concept and something I've had a lot of interest in the last 15 years or so. And in my prior institution, we had an intraoperative MRI, and we did hundreds of cases in there. And for certain pathologies, I found it really helpful for pituitaries, for example. For some of these complex skull-based cases, the magnitude and length of the surgery is so much that adding additional imaging time sometimes can be a challenge. But certainly intraoperative ultrasound is one of the simplest things and cheap and easy. And I think we could probably do that even better. Ultrasound that you can integrate with your imaging. Intraoperative CT is relatively more straightforward. Sometimes a little cumbersome, but for a lot of this anatomy that the bony anatomy is the greatest interest. The CT can be helpful, but MRI in some ways is the most powerful, but has kind of the most cost in terms of time and money. So it's kind of weighing those pros and cons. We are actually in the process of building an intraoperative MRI here. So looking forward to having that capability.
Yeah, I agree with that. I think neural navigation is in the last 20 years have made a lot of, the technology has improved a lot, and depending on the situation, sometimes, as you said, portable CT scanner to rescan the patient if I have any concerns about what's going on. But yeah, I'm looking forward to have the MRI available to us in the future to add into what we're doing.
Yeah, we talked about pediatric skull base and our experience in St. Louis, and I think this is true around the world, that in a number of pediatric brain and skull base tumors, those kids get reoperated on up to 10% of the time for residual tumors. Some of the pathologies, getting every last little bit about it is really critical to the outcome of that kid. And some of these intraoperative MRI techniques have reduced the rate of reoperation to close to zero, because you really get near real time. And so that's one example where I think it's kind of a game changer, not only kind of from the medical surgical standpoint, but the thought of approaching the parent and telling them you're taken back for a second operation, that's sometimes a tough conversation.
So I was curious from the two of you, in surgery overall, and I think particularly skull-based surgery, which is more innovative, we're seeing a lot of push towards more minimally invasive techniques, very minimal exposure endoscopic techniques. And then there's also a lot of interest in AI and robotics. So I was curious as to your thoughts on the future of skull-based surgery.
So
go ahead, Arnie.
Yeah, so as we have been using endoscopic surgery in our field for over 20 years, both for anterior and lateral skull base. And Mike and I have done cases in which we combine both approaches. You have seen the size and location of some of the tumors we had presented. And for those, sometimes it's very difficult just to do one or just the other. The other day, Mike and I were doing a huge cholesteatoma in which we had to overzone the extraoratory canal. And we did a traditional approach, and then there were some corners and crevices that we could not get into without exposing the patient to more morbidity. And then we took out some endoscopic instruments and scopes, and we look around the corner, and we found more tumor that we removed, and we did a great cleaning for the patient, and hopefully he'll be disease-free forever or for a long time. So it's a very important technology. I haven't seen any AI available to me intra-op at this moment. I don't know if Mike has had any other experience with this.
Yeah, so a couple thoughts. One that I could give you a few hours of more presentation about some of these things that I could talk forever about it, but that's just you want to hear it. But for some of the minimally invasive, if you will, approaches, there are now some big tumors, the anterior fossa, for example, that I used to maybe use a great big bifrontal craniotomy, and now I might do a little eyebrow approach. Might do a little 2-inch incision on the eyebrow and remove it through that. So a much smaller footprint. And as I already said, sometimes using endoscopes and things to look around the corner. We do a lot more endonasal surgery, which maybe in some senses is quote less invasive than a craniotomy for some pathologies. Chordomas, and it's kind of been a game changer for chordomas. And then certainly a lot of technology is introduced. I mean, for example, interface of the surgical microscope with the surgical navigation. So we can take those preoperative images that we got, they're in the navigation. We can have them in kind of a heads-up display in the microscope. So we're looking at the live microscopic image, but also in our mind's eye or in the microscope's eye, kind of show us where the tumor is, and you can kind of program some of that to say you're getting, within a centimeter of this structure or that structure, and people have talked about robotic use of drills and things, and that may be in the future. I mean, it's hard to match the sort of the technical skill and precision of a neuro-otologist, doing these sub-millimeter bone drilling. But I don't know what you think, Arnie. Maybe someday you could, a robot could drill the mastoid like a neuro-otologist, just like you see, they're doing sculpture with laser drilling and things like that. So it'd be interesting.
So when I was still in the Navy, we were trying to connect through the internet to a Da Vinci robot, so we could has someone closer to, or abroad doing a surgery, and we jump in through the Da Vinci, and it didn't work very well. And it didn't work very well for multiple reasons. Like, hey, it took me 3 computers to get to you today because I'm not in my usual office. So the whole idea was to support battlefield surgeons from the mainland during the war, and that didn't work very well, so we stopped because it was not safe. So maybe someday as technology continues to improve, but you need very reliable, consistent technology. And nowadays, then you start in the meetings, people start talking, what about if someone hacked into, because apparently Da Vinci, for example, doesn't have a good security software, so there is a lot of things still that we need to sort out, but certainly technology continues to grow. I went to the American College of Surgery in San Francisco, and I saw a bunch of taxis just driving themselves, technology, it's improving, and we should certainly continue to improve with technology.
I wonder, Dr. Ho, or some of your colleagues online here, things that are coming down the road in radiology, advances in imaging and integration of that in our clinical care. What you think the future holds?
Yeah, I think there are 2 major topics, right? One is the image acquisition, and one is the image sort of post-processing / analysis. So in terms of advanced techniques, you and I have talked about this. There are a number of different ways to interrogate tissue that give you biologic properties beyond standard anatomic macrostructure, right? So I think we as radiologists are relying a lot on, macrostructure, and there's quite a bit in terms of perfusion, metabolism, microstructure that can be interrogated, which can be actually more useful to the skull-based surgeon. For example, even just MR elastography for tumor stiffness, right? And for tumor-brain interfaces. So that's one thing. The other really important thing is, like, we've had a lot of impact from AI in the field just because we have all this retrospective data stored in PACS, right? And so looking at that, I think, the biggest thing I did want to highlight was the role of human annotation, right? So that's even more the case in surgery, because you have experts doing, their own very specialized techniques at very low end for training. But even in radiology, we see that it's garbage in, garbage out, right? So the idea is that you have to ask the right questions, and you have to really combine the data sets, but there's so much heterogeneity in terms of different databases, right, behind firewalls, that it has been very challenging, particularly for MR, which is very important for skull base. CT is a little bit easier. So again, I think there's a lot in terms of just getting the publicly available open source databases for training, and then having human expertise involved in asking the right questions. For low end things like pediatrics, very specialized complex skull-based tumors, it's going to be a while before, and I think it's more of a human-machine collaboration than a replacement. But there is quite a bit, I think, as of now, the sort of cutting edge in MR, like 7 Tesla MR or photon counting CT, these are still being exceeded by the software, right? So you're seeing the software exceeding the hardware advances, and it's also much more accessible for people around the world that can't afford these expensive scanners to actually, generate these images based on more, more accessible technologies. We're seeing things like low field MR, right? So Arnie mentioned the kind of like, remote scanning and being able to deploy, technologies in ruggedized, right, WAR areas or rural areas. And so I think just being able to share data, be more connective, have public databases, and then be able to essentially utilize software to improve image quality is really going to be key to, the future collaboration and being able to provide the data that you need to plan your surgeries.
Great.
I think there's a question, if we go the time, Pauline, just a minute or so.
Yeah, I see one question. In appropriate cases for radiation therapy versus surgery, in terms of life expectancy, what range do you favor, radiation or surgery? So kind of a broad question, and it depends a lot on the pathology. For a lot of benign diseases, sometimes a question of surgery versus radiation or both. For a vestibular schwannoma, for a medium or small sized tumor, particularly an older person, radiosurgery may be an option. In some cases, we resect as much as we can, then radiate the remaining part. For more malignant pathologies, it's usually a combination of, if appropriate, surgery followed by radiation and/or chemotherapy. So it's it's even a bigger part of the multidisciplinary team, the surgeons, the radiologists, the medical and radiation oncologists trying to make those determinations. And again, as much as we can try to understand that pathology, from the imaging, sometimes even before we start down the path, making a treatment decision that's helpful.
Fantastic. Seth, I think we need to wrap up now. And thank you all for joining us. And thank you to our speakers, to Mylan, Simon, as always, for organizing things like this, and my co-host, Seth here as well. And from the ASHNR and ESHNR team, thank you very much.
Thank you for having us.
Bye.
Thank
Thank
you.
you all.